we're going to today's talk, rethinking healthcare to make research accessible for Latinos, understanding the barriers and solutions, because let's keep this positive. One change that I will add, I was recently appointed as an assistant professor on the tenure track in the Division of Geriatrics, but everything else was correct. Well, let's start a couple of disclosures. So I have a K99 from the National Institute of Aging. Some of the results that I'm going to be sharing today have been supported by research from as a REC scholar, but also from research sponsored by the Wisconsin Partnership Program and the CTSA here at the University of Wisconsin. Probably I'm preaching to the choir. We know that Alzheimer's disease affects different races and ethnicities at different rates. And with African Americans having a 4% prevalence of Alzheimer's disease and dementia, compared with 10% of non-Hispanic whites, 12% Hispanics have this disease, and this number is just expected to climb by 2060. And I think the main point when I start with this is just to remember, just by 2030, 6 years down the road, we are expecting that 40% of those affected by Alzheimer's disease and dementias are going to be Latino and African Americans. 40%. So if we think about this, unless we prepare our workforce, or unless we prepare our research systems to adequately engage Latino and Black communities into research and healthcare, we are going to be failing them for the future. We know right now, most clinical trials recruit less than 10% of people is from historically underrepresented backgrounds. And this, of course, includes Hmong, Asian communities, Native American communities. There's a lot of groups that we are right now excluding from research. And again, they're going to be 40% of those affected by Alzheimer's disease and dementia. We probably, I won't delve too much in this, but this is what's happening. It's not 10% is a nice number, but when we go deeper into the weeds, we see that studies like aducanumab, we have less than 1% African Americans. And I think it was 4% Latinos, one Native American in the whole study, and the placebo group. And all of these are ramifications down the road. But then let's think about why must some of these things happen. I think I like to start by going with the participation in the research is directly related to the pool of potential participants. Based on the statistics, between 50 and 60% of people will receive a diagnosis. So we're talking that number is already shrinking. So when I started presentations with Rethinking Healthcare, that's a huge step. How can we get more people to get the diagnosis so that they could be eligible for participating in research? And then there's other questions like how many people actually will participate in the research? And I invite everybody to think about a study, the inclusion and inclusion criteria that you have seen in the past. One exclusion criteria that I always hate needs to speak English fluently. That's it. Or no, we don't accept people that speak other languages. That already starts decreasing the pool of people that could potentially participate in research. And I will say the following study is coming from FDA. I'm going to mention some statistics from FDA. FDA has recognized that this inclusion and exclusion criteria many times are a huge barrier for recruiting into research. 60% of the people studies have exclude people due to organ dysfunction, either an AST, ALT, creatinine, GFR above a certain threshold. Up to 50% of the studies have exclude based on age limits, and 68% of the studies exclude based on comorbidities. When we think that in the United States, about 2/3 of the population have at least 2 comorbid conditions, we are potentially excluded 75% of people from many clinical trials. And and this is some of the results of that study, the graph that's showing us. And I would like to point out the purple line. 3/4, 75% of the studies exclude 55% of the potential eligible patients or more. All of this is based on the inclusion and exclusion criteria. So when we get to the same graph, let's put some numbers to it. If we think that 1,000 people with the MCI or dementia, but only 50% of them will receive a diagnosis, we have a potential population for studies of 500 people. If due to the inclusion and exclusion criteria that we have in a particular study, we might end up excluding another 375, leaving us 125 people. Based on many research studies, we tend to invite about 10% of the population. And think about, sometimes it's about timing, who is the recruiting center, how many people is available on the study team. We cannot be everywhere every time. So about just 10 to 20% of people in the best case scenario. This changes, of course. And the study, they refer that African Americans, Black people, they refer about 16% of them have been invited to a study, but compared with only 2% of Asian Americans. So in average, it's about a 10%. Let's keep that number, but that might change. And the good thing is that once you invite somebody, 45% of them will actually say yes, 45 to 50%. So when looking at this graph, the first thing I want to highlight is that sometimes we're afraid of getting the rejection of people saying, I do not want to be part of the study. But look at this, 900 people was excluded before we even ask. 900, 90%. And all of these little things are related to the healthcare system. We know that the diagnosis is directly related to the healthcare system. How can you invite somebody with MCI if they don't have an official diagnosis? What about the inclusion and exclusion criteria? If the exclusion criteria is somebody with diabetes or uncontrolled diabetes, how many people will be potentially eligible if they have adequate access to diabetes management? Here, there's a lot of people that wants to help, but they never get invited. So let's rethink access to increase the diagnosis. That's the first step. And I want to make sure that I explain access. This is the definition I'm using. Timely use of personal health services and the factors that facilitate or impede their use. In other words, the right care at the right time, at the right place. According to the Behavioral Risk Factor Surveillance System, about 40% of the Latinos with self-reported cognitive decline have one or more barriers to access to care. Any care, not just ADRD care. These are the most common barriers. Lack of health insurance, costs, because even when you have the health insurance, you need to be worried about copays and deductibles and how much is going to be the medication. Couldn't get an appointment soon enough. The wait time at the office was too long to see the doctor, or you didn't have transportation. And this particular one was unique for Latinos. And this is something that we need to think about when we are talking not only about research and healthcare, but everywhere. Talking about caregiving support, talking about services. Transportation is huge. No matter that you live in a city or you live in a rural area. When we think about symptoms, sometimes we might think that it's as easy as, so where did I put my glasses? I couldn't find them. Oh, I just went to the doctor because I feel there's something wrong with my memory. Within reality, it's this huge process and this huge game. This is what we have seen in the interviews that we have done with over 50 different patients, older adults, caregivers. Usually people that start developing some symptoms, they start to try these compensatory mechanisms. Oh, I'm just distracted. Let me just put some Post-its. Oh, let me call my comadre. Let me call my sister. She had something like this. I just take a supplement. I'm just stressed out. And after all of these things fail, that's when they start, should I go to the doctor now? They start thinking, do I really need to get medical attention? But even at that point, they start like, I just probably getting old. This is nothing. I'm just going to mention this in my next appointment. I'm just going to keep an eye on this. This is just stress. And I love that one because I have heard it so many times. After things keep progressing, that's where like, okay, I need to go. I need to do something. Do I have the resources to do this? Is my insurance valid? Do I know where should I go? Do I have money left this month for potential copays? Who can take me to the appointment? And particularly, many adults are no longer driving, so oh, I need to wait for my son to be out of work, or I need to wait for my granddaughter to be available, and she works and she studies all days. Organizing those resources and playing what I call the telephone game. You call the doctor, try to set up an appointment. Oh, the scheduler is not here, or let me transfer you. I'll call you back. We need a specific test. And you get the call back, you miss it, and you try it again. And it's this full game. And I have trouble sometimes connecting with my own doctors. And I have a doctorate. I speak English. I have insurance. I'm not worried about costs. What about people that do not have all of those facilities? Our healthcare system is not designed to be friendly. And that's the first thing that we need to realize. Every step of the way is a roadblock. And that even happens, that transfers also when we are able to make the appointment. Because all of these things are affected by culture, education, literacy, language, awareness, and those keep happening. Then all of this is keep affecting what's happening in that appointment. So let's rethink what appointment looks like. I want to start by saying that we ask people, would you go to the doctor if you were having a memory problem? We asked this, English and Spanish. We got over 282 responses. Over 50% of these are from people from underrepresented backgrounds. So 85% of these are from people from underrepresented backgrounds. And overall, 60% of people say, I want to see a doctor. I want to talk about this with a doctor. So we'll need to start by thinking that people want to come. They just don't know where to start. And even when they come, many times they're fear. 44% of Latinos will discuss confusion or memory loss with a healthcare professional. And this is something that we have really go in depth in our interviews and in many of my research projects. These are some of the things that people said. If this were important, they will ask me about it. So when I see a Latino patient, I usually say, oh, what brings you here? Or how are you doing today? And usually the answer is, I'm good, thank you so much. How are you doing? They are the doctors, they're here for something. But many times they think that if they don't ask me about it, it's okay. If they ask me about my diabetes, that's fine. The hypertension is fine. If there is no more time, well, those were the two important things. I have heard the following too, and they break me every time that I hear something like this. I don't want to be a bother to the doctor. Maybe next time. Why they don't ask something? Because when I ask things to my doctor, they look annoyed and there's no point. This is what people think. And it's more common than we think. But even from the physician's perspective and the PCPs, we know why this happens. We have very short appointments. And this is coming from an interview that we're doing with PCPs. This project I was led by Dr. Perales Cuchal. The average visit is 15 minutes. If someone comes with a list of 6 or 7 issues, there's no way we can address that. But we try. So that ends pushing me behind. If I see someone that has got more complex, we might have a 30 minutes appointment, but that still fills up very easily. Some are complex and require additional management, a lot of thinking and planning, so time is always valuable. When our appointments are 15 minutes to manage complex conditions, and remember, 75% of Americans have at least 2 complex conditions, there's never gonna be enough. And this also is affected by the low number of healthcare professionals that identify Hispanic, Latino, or that self-identify from an underrepresented background. Latinos are 19% of the US population, but we are only 6% of physicians, 8% of nurses, and I don't even want to know the number of nurse practitioners, 13% of emergency medical technicians, and 70% of health aides. So that means that there's a huge discrepancy here. But what happens when somebody is able to see a doctor or a healthcare professional that looks like them? This is proven multiple times, 100 times, thousands of times. They're more likely to receive preventive care. They're more likely to bring up new complaints. They're more likely to continue follow-up care. And again, this comes over and over and over in interviews and different research projects. People have told me, my mom was diagnosed with dementia, and the doctor said that we needed to start thinking about putting her in a nursing home. We never went back. That's it. That was a no-no. That was not culturally appropriate. And those type of things happen every day. And again, let's think about how these have implications for research. If you cannot get somebody to continue treatment, to get a diagnosis, to get a management set up, how can we even invite them for research? And let's think more a little bit about this intersection. Again, what happens in research affects healthcare and vice versa. Let's start with the first point. 1 in 4 Black and Latino, Hispanic older adults have experienced discrimination with seeking healthcare. A quarter, 25% or more, have experienced discrimination or experienced healthcare. And of those, another quarter have said they did not get the care that they needed. 27% of the people that have experienced discrimination say they did not get the care that they need. And each time that there is a discrimination, unfair treatment, miscommunications, we are affecting the trust in science, in healthcare, and clinicians. And when people don't trust us, they don't trust the treatments either. That's why this is a study from the Alzheimer Association. There was a survey. When they asked people, do you trust that if there's an Alzheimer's score available, it will be equally distributed, regardless of race, color, or ethnicity? These numbers don't impress anybody. But 50%, 53% of Black Americans say, yeah, yes, that will happen. But that means that 47 of them say, nope, it's not going to be distributed equally. So we have to think about every time that we invite somebody to participate in the study, and we say, will help to find the cure. They look at you like, yeah, for who? Not for my people. But there's things to be done. And remember, I started at the beginning. Let's keep it positive. According to CDC, a few of the things that we can do. The first one, deliver all health-related services in a culturally appropriate manner. This might include providing the necessary patient support, translators, patient navigators, and also adjusting what we're doing to our community. Think about recommendations. Think about every time that there's a research study that you need to have 25 different signatures, how many cultures do not use signatures or written language? Ensure that clinicians, and I will add here, research staff show awareness and respect for the culture we provide in care. Think about nutrition recommendations. Oh, you need to be doing the Mediterranean diet. Like, you know what's not in the Mediterranean diet? Plátanos, plantains. You know what's the base of Caribbean culture? Plantains. So it's important that when we do recommendations, we are aware of the culture and not just disregard, like, no, plantains are bad, don't drink that, don't eat that. Because people feel discriminated, like, hey, plantains are my life, how are you gonna do that? Collect and report race and ethnicity data on all patients and research participants, and educate staff on patients on why this information is an important part of making sure populations are receiving equitable access to care. But also remember to look at the data and make improvements. Asking for the sake of asking without actually changing what we're doing is not helping anybody. People want to know why you're asking those information. And this is something that every time that we do a research study and we're asking for socioeconomics, I start by that saying, hey, the following questions I know can be a little private. This is what we're getting. We are getting this information to make sure that our solutions or results will be able to help anybody, no matter how little they make. We want to make sure that we hear from everybody. That's why we're asking you this information. It takes extra time, but it's really helpful. I'm thinking about culture. It's more than language. This is for, I'm going to tell you a few results from a study that we did during the pandemic about health communications regarding COVID-19. So this was an announced flyer from CDC that says you need to stay 6 feet apart to help us in one of the prevention mechanisms. But this never really fly on our social media websites. When we did other content like this, again, this was in Spanish. We still keep the Spanish, but did other things like, hey, some things for Halloween. Let's celebrate our culture. Let's use Dia de los Muertos. Let's celebrate our foods. And we have a student doing a video about how to do chilaquiles. These were well received. People felt connected. People referred that I think they care about me and they know that what I care about. And I'll show you now why this matters on health communications. So we have this link. We just shared a link in Spanish, again, trying to reach Latino communities. Hey, there's some information about the vaccine. Take a look. This is coming from the Latino Health Council, Consejo Latino para la Salud, a nonprofit organization working in Wisconsin for over 25 years. They are very well known in the community, and we partnered with them during the whole pandemic on this project. So we shared this link, and 77 people were reached. Okay, maybe we need to have a little better image, something to call attention. Let's try something else. Okay, get your vaccine and a little cute kid with his mask. Yeah, we just reached 78 people. Okay, let's try something else. Maybe what we need is real people. So we shared a video from Dr. Armando de Alba. He's at Nebraska. He's a primary care physician. And he was sharing when he got the shot. This is how I got it. This is how I feel. He was a couple of little videos about 30 seconds each. We got more people. We got 138 people reach. So there was interest. People like to see real people. Then somebody proposed to me, we should get Ricky Martin to do this. Maybe he can get the message out. We did not get Ricky Martin, but we shared some information from Dr. Juan Rivera that he works with Univision, is a physician. He does many of the TV segments, sharing information. And again, we just reached 163 people. You know what worked? When we have people from the community sharing the same message. This is one, la señora Yolanda Salazar. She's one of my advisory group members. And she's very well known in the community. 2,000 people. That's just a single picture saying, if you are 65 and above, you can get your shot. Call this number for more information. 2,000 people. And when you see the comments were, how you feel? Is it safe? Can I still get it? Do you have any fever? So in the different focus groups and evaluation of this project, people said, we want to see real people. We don't want to see animations. When we see somebody that I know, I feel that this information is applicable to me. The same message applies to research. If the message is coming from somebody that they know, they are more likely to say yes. But sometimes we cannot invite people directly, right? Sometimes we need to use flyers. And I'll tell you the story about this flyer. So this is a flyer for one of my own studies that I asked people to participate in a community advisory. When I asked the community advisory board members to critique this flyer, the first thing they say, I wish the pictures show Latinos. When I pick these pictures, it's like, okay, they look general enough. I don't ambiguous at best in ethnicity, but they did not see represented themselves. But when I change the pictures and we include this example from CDC, this is one of the pictures that we're using right now, they did feel connected. They felt that information was for them. And even if the flyers in Spanish, they still wanted to see it in somewhere that they could participate even if they only speak Spanish. Little details. Look at the little details. The colors, they love bright colors. They didn't want to see just black and white. They want to see things that call their attention. This also relates to the workforce development. We know, again, that asking for somebody to participate in research or to receive healthcare, we get better results when they look like them. That means that we need to invest in some support programs for students from underrepresented backgrounds to make sure that they have the support that they need. And this includes not only racial and ethnic minorities, we also need to think about rural communities, people lower socioeconomic status, and sexual and gender minority groups. Medicine is really hard. Research can be really hard. And unless that we support more programs, most people is not going to be able to make the breakthrough and keep in this workforce. And that has implications in recruitment. This is the research staff that my team and that project that I was talking about, social media. Everybody in this group was from almost everybody underrepresented group. We have Native Americans, we have Latinos, Hispanic, we have Black community represented in this group. That meant not going by skills, but going by intent. All of our community advocates had no experience using social media, doing videos, or being an influencer. Zero. That meant that we hired them by the other skills, the communication skills. Can they share? Can they talk? Do they know their community? Are they really engaged? And then we trained them on those technical skills. That means that it takes time. It took 6 months for them to feel comfortable creating messages for social media. So research staff that looks like us means we need to plan, we need to be intentional. It's not just, I need somebody with qualitative skills, that's it. It's like, I need somebody that can speak to the people and I will train them on the qualitative research. Well, that goes to the next step. Rethinking the research role in healthcare. How can we make sure that what we learn in research is applicable in the healthcare system? And that's also part of the recruitment. Every time that I share a study, people ask me, who will benefit? Why does this matter? I get way better responses when I say, this will help us to insert the benefit here. And people say, I will do that. I will do research if I know that the results will make life better for my sons, my daughters, my granddaughters, my community. So I always keep that in mind in all of the recruitment materials. How this will change healthcare. Oh, this will help us to figure out if A is affiliated with B. So what? That's not really entertainment. I don't know why that's important, but if you say this will help us to change somebody's life, easier to recruit. And of course, that also involves the incentives. Think about the little things. It's not only about, do I get money? It's like, where this is? Do I get transportation? Childcare, elder care. What's the benefit for somebody? Oh, I could participate, but then that means that will be reported to my social security, and I don't want that. All of these little things affect how people interact with the research and decide if it's worth their time to participate. Finally, and I think this is the last point, rethinking our relationship with the communities. We need to establish trust, so we are not parachute investigators, just coming and inviting people and then leaving, but being on the ground, working with them and making sure that there's a benefit that they will receive. And those benefits do not have to be monetary. It could be on training, it could be on workforce development, it could be on many, many other things. It's about establishing those relationships and talking to them and figure out what's important to them. Always figure it out, keeping your work, keeping the channels open. It's a lot of communication, a lot of talking, and identify the right people for the right projects. I think I just want to highlight that sometimes you don't know who the right people is. So you will play around and talk to different people and keep bringing them back and keep coming back to talk. With that, healthcare and research is a chicken and the egg situation 100%. But again, what happens in healthcare affects research. What happens in research affects healthcare. We have heard from many people that do not want to get the vaccines, even though they're approved and they've been on the market for years because Tuskegee or because of the experimentation with Puerto Rican women and the pill. So everything is interconnected. So we should stop thinking that, oh, that doesn't apply to me, because it does. We can make things happen, and I hope to get some questions right now.